Welcome, welcome, welcome. Today we are going to be having our inaugural episode of a new Facebook Live series we're going to entitle Focus. Series will include myself, Dr. Hussein Kermali, as Chief Medical Officer here at St. Mary's Hospital. Each month we are going to highlight one of our clinical departments and share with you some of the insights and new technologies that they'll be using here at St. Mary's Hospital and for the patients in the Waterbury market. We're going to kick off our Facebook Focus series with our GI department. And this team here offers some of the most comprehensive and state-of-the-art diagnostic and therapeutic interventions available in the gastroenterology world. And our guest today is Dr. Priyanka Chugh. Dr. Chugh joined our staff in the summer of 2020. Big year. She comes to us from Mount Sinai in Queens, from Mount Sinai School of Medicine in New York. Clinical interests include complex liver disease, inflammatory bowel disease, colon cancer screening, peptic ulcer disease, and GERD. We'll talk about that.
Thank you. Thank you for having us. This is really exciting to be part of the Focus initiatives at St. Mary's. I think it's a great way to reach out to our patient population in the community and get our name out there as well, and talk about the different departments. And I believe I became a gastroenterologist because GI is a very, very comprehensive field. It's both procedural as well as intellectual, and but sometimes it's hard to come across and to tell patients all the great stuff that we do, because a lot of people just think that it's all about either colon cancer screening or, oh, my belly aches. But there's so much more that we gastroenterologists can provide to our patients, and hopefully we can get to talk about a couple of those things today.
So let's get right into it.
Yeah.
What are some of the services that you guys do provide here at St. Mary's Hospital?
Yeah, so we are a pretty comprehensive group. We have 7 physicians and about 4 advanced practice providers in our department here at St. Mary's, and several others at our sister hospitals as well. But especially with the addition of the newest member in our department, my colleague Dr. Wander, I think we have really broadened our horizons. We have gone from a general gastroenterology department to more therapeutic and more advanced technologies as well. We offer everything from esophageal, diagnosis, as well as management and procedure-based initiatives involving everything from the esophagus to the colon, including the pancreas, the hepatobiliary tract, gallbladder. And to name a few of our procedures, we do upper endoscopies, both diagnostic and therapeutic. Colon cancer screening is a huge initiative, not only for us, but also the American College of Gastroenterology. And then we have also branched out into inflammatory bowel disease and liver diseases as well. So we do it all.
So let's talk about one of your specialties, colon cancer screening.
Sure.
I think that's a big one that
Yes.
we've been hearing about. Definitely one of the things that have impacted our patients, especially coming out of the past year and a half, 2 years that we've been having. We've seen a little bit of a decline on that.
Of course.
Tell us about what we're able to do for colon cancer screening, what you're able to offer, and how it's safe now continuing going forward.
Yeah, so I think change is the only constant. That's what I live by, the principle. And GI is a rapidly evolving field. And similarly, colon cancer screening has evolved rapidly, both in the technologies that we offer for colon cancer screening. So the one most important thing that has happened in the last decade, especially regarding colon cancer screening, is changing the age at which screening starts now. It's now 45. So for average risk individuals, the screening age has dropped from 50 to 45. So I think that's a very, very important message, especially to our community providers, our primary care practitioners, GPs, and family medicine practitioners, because we get a ton of referrals from them. And even now we see that this 5 years of age, 45 to 50, a lot of people are falling through the cracks because just the word isn't out there that
Sure.
colon cancer screening has bumped down to 45. So yeah, anytime you see a 45-year-old average risk in the office, in the hospital, anywhere, at church, refer them for colon cancer screening. So that's
now it's not just
one.
the 50th birthday party presents.
Exactly.
They
It's
get
not.
it at
It's the
45 now. 45-year-old
It's so
birthday
awesome
party.
to
Awesome.
take the prep that we just take it a little bit sooner. So coming back to the prep comment, so there are several different ways that we can screen for colon cancer. I like to divide it up into whether it's direct screening versus like the two-step method or the one-step method.
Mm-hmm.
So, the one-step method, yes, it's the instrumentation with a colonoscopy.
Sure.
And that is by far the gold standard. It is the best way to screen patients for colon cancer because it allows like direct visualization of the colon. And
So you're seeing all the nooks and crannies all the way
correct.
through.
I mean, no test is 100%, and even with a colonoscopy, the miss rate is about 15%, even in the hands of the best endoscopist. But yes, it is still, we are taking our time in there to expand the colon, to inflate the colon, look behind every single nook and cranny that we can. And the best part is that if we find something, whether it looks like something precancerous or something just small and benign, we have the ability to remove it at that time.
Right.
So the patients don't have to come back, exceptions yes, but they don't have to come back for this, or they can walk out of the facility feeling comfortable that they've had a good exam and things were taken care of.
Gotcha.
Yes, there are certain patients that prefer not to go the invasive route, and for them we have the two-step method. So we have stool tests like the Cologuard or the FIT. The occult blood test has really been debunked over the last few years. It really doesn't provide us with a lot of information, and there are tons of false positives. But either the FIT or the Cologuard are one of the best stool tests available with a very high sensitivity and specificity. But again, if things come up positive on that, then the next best step is the colonoscopy.
Gotcha.
And
So those tests, can you describe those tests just a little bit?
The stool
FIT test or the stool test?
Yeah, I mean, they're relatively easy. The primary care or the gastroenterologist orders the test. The order goes straight to the insurance company and the company that provides the test, and they mail the kit home to the patient's home. So it's very simple, it's reliable, it's non-invasive, and you literally just, as a patient, have to give a stool sample, pack it up back in the kit, and send it back.
Gotcha.
And then, the lab processes the results and sends it back to whoever the ordering physician or the practitioner is. So it's very simple. It doesn't even require a prep.
Yep.
So, patients who maybe tend to be a little bit more complicated medically, and there's a risk from an anesthetic standpoint to put them under for a colonoscopy. I think for those patients it's an excellent way to at least screen them.
Yeah.
And then of course if they turn positive, then there's a risk benefit discussion to do a colonoscopy on those patients.
Sure.
But certainly I think there is a role for the stool tests. However, I would still be I am a very strong advocate of direct colonoscopy for colon cancer screening.
And is that safe to do given our current situation with what's floating around in the air, let's say?
Yeah, I mean, yes, absolutely. I think, especially in the Northeast, I think majority of us have taken a lot of precautions. Our vaccination rates are extremely high. Tons of residents of Connecticut, as well as a lot of healthcare providers, have gotten their booster shots as well for coronavirus, and a lot of us are now even vaccinated against the flu. And we are testing patients who come through the door for elective surgeries up to 48 to 72 hours prior their procedures. And so we are taking all precautions. Providers, nurses, staff are all wearing, we wear our N95s, our headgear, mask, gown, everything in the room. And we have pre and post phone calls to ask patients their symptoms, their temperatures. Everyone's getting screened. And any hint of even a cold, a cough, or a congestion, we are very, very cautious about getting those patients in through our doors.
Gotcha.
For elective cases. So I think, this must be too much information, but I had a colonoscopy last week and I felt really safe. It was fine. It went well, and I didn't think that I was being unnecessarily exposed to any bug in the air. I mean, things happen, but they can happen regardless of the pandemic. But I think just coming back to the pandemic, I think we've come a long way, and I don't think anyone should be really hesitant on getting a colonoscopy or any elective procedure for that matter.
Great. Yeah. Thank you so much for that.
No problem.
Let's shift gears a little bit. Let's talk about acid reflux.
Yeah,
sort of the other side of the body, and let's talk about some of the tests or some of the newer technologies with regards to, what used to be just Papa Tums or Papa Rolaids. It seems to be a little bit more thought-provoking these days.
Correct. No, definitely. I think acid reflux can be, anything from just, like you said, it's simple. It's like, okay, it's dietary, it's simple, it's let's just pop a Rolade or a Tums or a short course of like an acid blocking medication and see how things go. But, when a patient comes to us for acid reflux, they've generally tried everything. They've tried the diet, they've tried the exercise, they've tried the medication trial, and things are not going their way, and that's why they've come to us as gastroenterologists. So from that perspective, we have advanced diagnostic, whether it's imaging through barium esophograms or diagnostic procedures like upper endoscopies. We have Bravo testing, which is a capsule that we basically implant in the esophagus that the patients go home with.
Okay.
And they record their symptoms on a little recording device and maintain a diary. And, we study that data and see what type of reflux that the patient is having to guide their therapy appropriately.
Wow.
And soon we'll be starting something called high resolution manometry, which gives us a little bit more insight into the swallowing mechanism or the peristalsis of the esophagus that also can give us more insight into the pathophysiology of the patient's acid reflux.
Wow.
So yes, there's a lot more stuff going on than just popping a Rolade or a Tums, like you said. Yeah.
Wow.
So there's definitely more, like a lot of fine tuning even in the field of acid reflux.
So when should a patient say, I need to come in because this is getting too far?
You mean in terms of acid reflux or just gut health in general?
Gut health in general, or maybe even acid.
Yeah, I think, I think patients are getting very informed these days. There's a lot of information available, like on social media, the internet, or Dr. Google. Like, how many times have patients come into our office and be like, we've Googled our symptoms? So I think patients are becoming very tech savvy.
Yeah.
So we do get, we get a ton of referrals for whether it's cancer screening or GERD or fatty liver. But I think the top 4 or 5 things that patients really walk into our door is like, persistent symptoms, whether it's persistence of reflux or persistence of abdominal pain, bloating, food allergies, intolerances, and I think like rectal bleeding. The other one that like really, raises alarm in patients are change in stool habits.
Okay.
Stool, whether it's the color, the consistency, the caliber, the frequency. And I think, patients are very proactive nowadays in getting their symptoms evaluated.
Right.
Yeah, because they hear things, they read up things constantly, and I don't think that wealth of information was available like even a decade ago. It's just this technology boom has like helped patients get more informed, and that's definitely helped them come seek medical help sooner.
And it's very true. Even talking to my siblings and what they talk about in terms of that adage of you are what you eat, and then they talk about all sorts of things, like the different types of food that they're eating, and my older siblings especially, but even some of my younger ones are like, hey, you got to eat this, that, and then you got to supplement with this, that.
Right.
And so they're very, very health conscious, and they attribute a lot of their health to what's going on in their gut. And I'm sure that's a huge field in and of itself.
Yes, I think that's a huge field. There's tons of research from NYU, Mount Sinai, and UCSF that are dealing with the gut microbiome. Dr. Martin Blazer, he has a huge gut microbiome lab in New York, and he's been doing amazing research over the last 2 decades on the gut microbiome. I think there is little information available on this field, but I think in the next decade, this field or this focus of GI is really, really going to boom. And I think we would be able to fine tune like kind of tweak the gut bacteria in certain ways to like cure a lot of diseases.
Wow.
Yeah, I mean, just as an example, there was a recent like study. This is all just like in vivo, like clinical research, animal based, that they did stool transplantation from obese mice into like skinny mice, and they were able to see like an instantaneous like weight change in the skinny mice. So
Wow.
there's a lot of this stuff going on. We know that in vivo trials have suggested like insulin or glucose regulation as well from stool transplant. We are using stool transplant in the field of GI for treating recurrent C. diff.
Yep.
That's definitely being used. There are smaller trials coming out in the field of inflammatory bowel disease, particularly ulcerative colitis, but I don't think that like the actual data is out there, but I think a lot of studies are going on. So we'll see a boom in the next decade.
Yeah, and it's interesting. We talk about this stool transplants. It's sort of, especially with regards to the C. diff, the severe diarrhea that people can get after antibiotics, especially as an infection, and it really does change the entire course of a patient's progress, especially if they can't respond to the antibiotics.
Yeah. I mean, even right now, the Infectious Disease Society guidelines suggest that for patients who have C. diff, we do treat them with a round of antibiotics. If they fail, you run a second group of antibiotics. But at the third point, or depending on the severity of the disease, fecal transplant is definitely in the guidelines. And we have done that here at St. Mary's, and I've done that at my prior institution, and we have seen like great results, and a significant decrease in the patient's like symptom scores, and that also translates that into like improved quality of life for the patient in the future as well.
So it's like step 3 in the process of something that we couldn't even take care of with the medicines that we have today.
Yes.
That's amazing. That's just amazing. So what are some of the other things that you're excited about in your practice that you're doing right now for your patients?
So like I said, I think we are like very excited to like start manometry, which is like very sophisticated esophageal testing. We may expand that into like the anorectal manometry, or that again manages patients with like very complicated like constipation or pelvic floor disorders that are again like treatment resistant or medication resistant.
Okay.
So that's definitely one. We are continuously trying different tools and equipments for therapeutic endoscopy. We are actually doing a trial with artificial intelligence software as well.
Wow.
That increases, or is at least designed to increase, detection of polyps on a colonoscopy. So that trial is ongoing, and I think these things will definitely evolve over the next like 5, 6, 7 years. I think we've never been in a phase where technology and medicine have like coincided, and there's so many like healthcare companies, startups, or just even like the established companies like Medtronic and Boston Scientific, who are really working with like endoscopists and procedural medicine specialists to build more patient-centric, efficient technologies. And I think we're seeing that slowly in the field of GI.
Yeah. I mean, it's all about the patient and making sure that it's easy for them and that they're getting the best technology that's there for them.
Exactly.
That's wonderful. So how are we doing that here at St. Mary's specifically?
So like I said, I mean, we are doing that artificial intelligence trial. We are also, we started to use like a new endoscopic suturing device recently called called X-Tac. So that's been, we're using disposable like, ERCP scopes as well. So that definitely improves patient quality and decreases rates of infection related to these procedures, and yeah, I mean, and plus all the other stuff that we are doing is also like, it just adds on and compounds to that to improve like better patient care and quality. And
you mentioned Dr. Praneet Wander and her presence here at St. Mary's and what she's able to bring to the table. Can you describe a couple of things that she's able to do from her side?
So I mean, she's a therapeutic endoscopist, so she's done an additional year of training after her general GI fellowship, and she focuses on the biliary, the pancreatic system, as well as the gallbladder. And she's able to do like very advanced procedures like endoscopic ultrasounds and ERCPs. So it's, she deals with the bile ducts, the pancreas, and it really delves into the field of GI oncology. So it's where cancer and gastroenterology like come together. And she is able to bridge that gap between gastroenterologists, oncologists, and surgeons in the therapies that she provides. So I think that's a huge service that patients in the Waterbury, Naugatuck, and the surrounding communities can get from her.
That's excellent. That's excellent. So if somebody wanted more information, how do they go about getting to you, getting to the team?
Yeah, I mean, I think the most direct way is to just call our phone number, and we'll give you all the details for that. I think we have it somewhere as well. Yes, it is 203-709-6646 is like our direct line as well. And then I think through your primary care provider, you can look all us up on the St. Mary's websites, whether it's through Facebook, LinkedIn, any of those social media outside, but just the direct hospital website through your primary care provider, and or just straight Google, you'll find our information too.
We are available. We are available.
Exactly.
Well, I mean, it's been great talking to you. Thank you so much for presenting at our inaugural episode of Facebook Focus.
Thank you.
And we look forward to continuing your team's efforts here at St. Mary's, and you guys are doing an excellent job.
Yes, absolutely.
So thank you so much for taking care of all of our citizens here in the Waterbury area.
Thank you.
Appreciate it.